Hello everyone, welcome to Pediatrics and Neonatology. This video is about how to determine the site of lesion in sudden onset of stroke presenting with hemiplegia without the help of CT scan or magnetic resonance imaging. Now follow these steps. Number 1. If hemiplegia, then first step is to just check whether there is facial nerve involvement or not. There could be three possibilities. Number 1. Facial nerve is affected on the same side of hemiplegia. Number 2. Facial nerve is affected on the opposite side of hemiplegia. And number 3. No facial nerve involvement, that is, facial nerve is normal. Now, when the facial nerve is affected on the same side of hemiplegia, this means upper motor neuron lesion of the facial nerve is there. Only lower half of one side of the face is affected in this case. This combination of hemiplegia and facial nerve involvement both on same side means that stroke lesion could be at 4 important sites above the pons level. Now these could be contralateral midbrain, internal capsule, corona radiata or cerebral cortex. These 4 sites have additional clinical features of their own, with the help of which we can determine the exact site of stroke lesion. Now when the lesion is in midbrain, there is ipsilateral third cranial nerve palsy, contralateral hemiplegia, contralateral facial nerve palsy, that is upper motor neuron lesion, and ipsilateral pupil is dilated and fixed. So if hemiplegia and facial nerve involvement are on one side and third cranial nerve involvement on other side, it means stroke lesion is in the midbrain. Now when the facial nerve involvement is on the same side of hemiplegia but third cranial nerve is intact, it means lesion is above the midbrain. It could be internal capsule, corona radiata or cerebral cortex. Now if the lesion is in internal capsule, even a minor lesion can cause massive damage. There is contralateral dense hemiplegia, that is upper limb and lower limbs are equally affected with zero power. There is contralateral facial nerve palsy, dysarthria, and contralateral homonymous hemianopia. Now key point in this lesion of internal capsule is that there is no cortical lesion, for example no aphasia and no cortical sensory loss. Now next is if the lesion is in corona radiata, there is no dense hemiplegia, rather there is contralateral monoparesis or monoplegia, only upper limb or lower limbs are affected. There may be contralateral facial nerve palsy, but no cortical lesion signs, for example no aphasia and no cortical sensory loss. Now if the lesion is in cerebral cortex, there is contralateral facial nerve palsy, that is upper motor neuron lesion. There is contralateral incomplete hemiplegia or monoplegia, and there could be seizures in this case of cerebral cortex. There is contralateral loss of cortical sensation, for example loss of 2 points discrimination. There is contralateral eye deviation, that is eyes deviate towards the site of hemiplegia. And there is contralateral homonymous hemianopia or contralateral lower, that is parietal lobe or upper temporal lobe quadrantinopia. Now if the lesion is in dominant cerebral hemisphere, there are also aphasia, agraphia, acalculia or agnosia. And if the lesion is in non-dominant cerebral hemisphere, there are also contralateral neglect, spatial disorientation, constructional apraxia or dressing apraxia. Now in the cerebral cortex lesion, with the help of the clinical features, diagnose the vessel responsible for the infarct. Now in the case of occlusion of the anterior cerebral artery, there is contralateral motor and cortical sensory loss of the lower limb. And in the case of occlusion of the middle cerebral artery, there is contralateral motor and cortical sensory loss of the upper limb. Global aphasia, that is loss of speech and hearing in the case of dominant hemisphere, and contralateral hemi-neglect in the non-dominant hemisphere involvement. There may be contralateral homonymous hemianopia, and eyes deviate towards the site of brain lesion, that is away from the hemiplegic site. Now step 2. Facial nerve involvement is opposite to hemiplegia, that is there is crossed hemiplegia. Stroke lesion is in the pons on the same side of the facial nerve palsy. Now in the lesion of pons, there is ipsilateral facial nerve palsy, that is lower motor neuron lesion, contralateral hemiplegia, contralateral hemisensory loss of the body, ipsilateral 5, 6 and 8 cranial nerves involvement, ipsilateral Horner syndrome, pupils are pinpoint and reactive, eyes deviate away from the site of lesion, that is towards the paralyzed site, and there is no third nerve involvement. Now we come to step 3. In this case, there is hemiplegia with no facial nerve involvement. There could be 3 possibilities. Number 1, this is recovery stroke. Number 2, stroke lesion is in medulla. And number 3, basal ganglia infarct is there. Now if the stroke lesion of medulla has occurred, number 1 possibility, lateral medullary syndrome, that is occlusion of the posterior inferior cerebral artery has occurred. In these cases, there may be contralateral hemiplegia, ipsilateral 5, 8, 9 and 10 cranial nerve palsy. There is dysphagia, dysarthria, dysphonia, that is hoarse voice. There is absent gag reflex. There is ipsilateral facial nerve sensory loss. There is ipsilateral loss of taste. There is contralateral loss of the body pain and temperature sensations. There may be ipsilateral ataxia, ipsilateral Horner syndrome, pupils are constricted, there may be vertigo, nausea and vomiting. Now number 2 possibility, there may be medial medullary syndrome. In this case, there is occlusion of the anterior spinal artery. In these cases, there is contralateral hemiplegia and there is ipsilateral 12th cranial nerve palsy. Now in the case of basal ganglia infarct, there is contralateral hemiparesis, contralateral hemisensory loss, ipsilateral eyes deviation. For example, in left basal ganglia stroke, eyes deviate towards the left. There may be ipsilateral mitotic non-reactive pupil and there may be resting tremors, chorea or acidosis. So if hemiplegia, eyes deviate away from the hemiplegic site, there is no facial nerve palsy and no third cranial nerve palsy, then lesion is in basal ganglia. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative videos.